This week on the BackTable podcast.
But I think in general, my rule of thumb is, if they've had 2 serial scans where they've maintained a sustained response with no other evidence of disease progression and they're clinically doing well, that's generally when I'm pulling the trigger to say, okay, let's have you go back and see the surgeon. I don't generally jump on the first scan because I want to ensure that response is maintained. There's been so many times where you kind of jump the gun too early and then you stop their systemic therapy and you're getting them teed up for surgery and they met out in the middle of that process. And that's the worst thing you could do for somebody. So I like to ensure that there's sustainability in the response before we pull the trigger on actually taking somebody to the OR.
Hello, everyone, and welcome to the BackTable podcast. I'm delighted to be your guest host today. This is an episode in conjunction with the SUO, and the topic today is we are going to go through a kidney cancer tumor board. I'll introduce myself. My name is Mark Ball. I am an associate professor of urologic oncology at the National Cancer Institute at the NIH. I'm required to disclose that I am acting today in my personal capacity, and views do not represent the federal government. I am delighted to have a star-studded panel today, and I'll have them introduce themselves and where they practice. We can start with Dr. Manley.
Thank you, Mark. So my name is Dr. Brandon Manley. I'm an associate member at Moffitt Cancer Center in Tampa, Florida. I work in the genitourinary oncology department. I'm a urologic oncologist, much like yourself.
Excellent. Dr. Hannan.
Thank you, Mark. I'm Raquibul Hannan. I'm a radiation oncologist. I'm at UT Southwestern. I'm a professor here of radiation oncology.
Excellent. And Dr. McKay.
Rana McKay. I'm a DU medical oncologist at the University of California in San Diego. It's an absolute pleasure to be here with you all today.
Fantastic. Well, I am super excited. So much like most of our listeners who participate in tumor boards at their institutions, that's what we're going to go through today. And these are real cases. Some of these are from my practice. Some of these Brendan also provided from his practice. But no one here has seen the whole slide deck, but there are no surprises here. These are just common cases that I think that our listeners hopefully can get some insights from. And what I often find at tumor board is that reasonable people can see the same case and come to different opinions. And sometimes that's the most interesting thing. So we might have areas of consensus and we may have some areas where we can learn from one another. So first case here, I chose this case because this is a common scenario. So this is a patient that presented. He was a 64-year-old man and he had some abdominal imaging for a workup for diverticulosis. All that sort of resolved. It was negative, but he was incidentally found to have a 3-centimeter renal mass. Otherwise healthy, just had an appendectomy in the past and good kidney function. So I think this type of case is probably going to be referred to the urologist first. So maybe Brandon, is this a typical case that you would see in your practice? And if it is, how do you sort of counsel a patient on what their options are?
Yeah, thanks, Mark. So this is a pretty classic case that, I think anybody who does kidney cancer sees a lot of these, the incidental diagnosis, typically a smaller renal mass under 4 centimeters. These are pretty common. So, first thing that I do when I see a patient like this is try and get a sense of what the patient knows. Obviously, being at a cancer center, I may be the second, third, fourth, but sometimes I'm the first, if they went to the ER. So starting by trying to get a sense of, what the patient knows, what they've heard, right? A lot of information before I even say anything. So I sort of know how to frame my discussion with them. Sometimes, as we all probably know, patients come in with their own idea, mindset of what they want, right? And so it's important to get that from the get-go because then you're sort of addressing the patient's needs on that sense. When it comes to this patient specifically for their mass, they have quite a few options. This mass looks like it's solid, obviously. I'm sort of guessing, but it looks like it enhances. So, statistically speaking, this is more likely than not a malignancy. One of the considerations here would be a biopsy to really prove that. I think the field has changed quite dramatically over the last several decades where we used to, think it was taboo to biopsy these things. But me personally, I tend to biopsy a lot of these small renal masses, especially in patients where they may not be the healthiest, or if I'm worried I'm going to have to take a kidney, I really want to make sure I'm doing it for the right reasons. So that's something to consider. But I also don't think in a case like this, in a healthy patient with a pretty sizable mass and in radiographic features that are pretty strongly pointing towards a malignancy, proceeding with surgery or some kind of intervention is also reasonable. A little bit depends on the patient's comfort level with that. When it comes to treatment options, this patient, 3 centimeters is sort of the typical landmark we use when we talk about ablative versus surgical having equivalency. So at 3 centimeters, I think it's still within the realm, and lucky for this patient, the location of the mass is in a pretty good location for ablation. It's not really close to anything. The colon's a little close to it, but I think they could get that off with some saline or something. So they would have that as an option. I think the gold standard still in this case in an otherwise healthy patient, 3 centimeters and above, would be a partial nephrectomy. So that would be my initial recommendation. But obviously tell them I'm biased, I'm a surgeon, but I don't think they're unreasonable if they want to get some more information with a biopsy or meet with my IR colleagues. I think those would be the ones I would consider in this situation.
Excellent. I think that all that sounds similar to my practice as well. Brendan, let me ask you this. You mentioned biopsy. I think biopsy is being increasingly utilized. Is it something that you use often in your practice?
Yeah, I do. When I say often, I guess I'm comparing it to historically through my training where I saw my attendings rarely getting a biopsy except for sort of the more complex cases. I don't think if I were back in residency and I mentioned getting a biopsy, my attending right then and there would be like, what are you doing? And they weren't wrong. It wasn't in a lot of our guidelines. It wasn't really an established practice. So that was the way it is. But I think the field is changing. Part of it is, as a surgeon, I really don't like it when I go in, cut something out, and find out it wasn't cancer or the patient didn't need that operation technically. Now, sometimes if patients are proceeding directly with intervention, I caution them on that, saying, listen, this isn't a guarantee this is cancer. And that's an important thing. It seems a little ludicrous. I'd never go in and take somebody's prostate out without proving that they had prostate cancer or something like that. So, those are the situations that I try to avoid. Unfortunately, they happen to all of us. The MRI are great, but they're not perfect. And neither is a biopsy for that part too. So I caution them on that. But I do think biopsy is becoming more common. It's just an extra way to ensure that you're selecting the right patient for the right intervention.
Absolutely. So you counsel the patient on these options and they say, doc, that sounds great, but I really don't want to do surgery. You've mentioned ablation. That is not really ringing as a great option for this patient either. Is it ever appropriate to do surveillance for a tumor this size?
So again, in this patient, how you describe them as a pretty healthy person? Yeah, they had some diverticulosis, hypertension, but I think we would all agree, especially those who do surgery, this is a good surgical candidate from everything I've heard thus far. So if that wasn't the case, then I think that definitely opens the door for watching these. In those cases for active surveillance, right, anything under 2 centimeters, it's well in our guidelines to monitor those tumors. Obviously selection based on the patient characteristics matter a little bit too. Sometimes I'm a little more hesitant to watch a tumor that's really central in the kidney and close to the vessels where I already know it's going to be difficult making it bigger, just potentially as long as I'm trying to spare the kidney. But in a case like this, in a favorable location, a couple half a centimeter here or there is probably not going to change my management. So from a surgical perspective, I'd be okay watching this. But there's a cancer perspective. And if the patient's really sick, has some comorbidities, then I think it's reasonable to entertain that option as long as the patient's on board too. And in those cases, almost for sure, I get a biopsy if at all possible to help sort of guide management. And again, if this is a clear cell, which this, statistically speaking, most likely to be, you just have to caution, there's good data from Mayo and other places, historical rates for the development of metastasis based on the primary tumor size. So something like this, about 3 centimeters, I think looking at that data, you'd estimate, probably a 1% to 2%, maybe up to a 3% chance if they had some bad histology.
Excellent. Well said. I'm going to throw things over to Raqib. Raqib, this patient, after meeting with the urologist, thinks surgery sounds okay, but wants to really explore all their options. And, their brother had radiation for their prostate cancer, wants to hear what's going on in 2025 with radiation for kidney cancers. In my training, just a little while ago, we used to say that renal cell carcinoma, there's no role for radiation. And that's really not at all where we are now. So can you kind of tell us what's changed? What does the up-to-date data say for treatment of primary renal masses with radiation?
No, absolutely. So renal cancer used to be considered radioresistant, but mainly to the older form of fractionated radiation, those radiation that was delivered over 5, 6, 7 weeks. Now, at that time, we did not have the technology to deliver the high-dose focused radiation to a target such as kidney, which, as you may know, moves with breathing. So it becomes much more difficult to target and focus the radiation. But now we do have the technology that is what is called the stereotactic radiation. You may often hear the abbreviation SBRT or SABR. With the application of SABR, we have seen local controls that are on the order of 95 to even 100%. So far, 3 trials have been reported, the Fast Track 1, Fast Track 2, and our own Phase 2 trial. And we have data that is about 5 to 6 years out. So reasonable duration data, reasonable number of patients, and we have been able to get local controls on the order of 95 to 100%. The benefits, of course, with SABR, it takes 1 planning session and then either a single treatment or 3 treatments. These are completely non-invasive. The patient is just laying on the table for about an hour and the maximum. This particular case, it's a posterior location, favorable location for us. The colon is about 1 centimeter away, which does not bother me as much, particularly because, again, with the advancement of technology, we are able to do adaptive radiation. We can even take into account daily motions that may be there in this colon. And we should be able to deliver and adequately offer local control for this patient.
Fantastic. Are there any locations or any type of comorbidities that takes SBRT off the table?
So comorbidities, no. I mean, comorbidities actually those are patients that we are seeing because they are not surgical candidates typically. Location-wise, and that's a good point, size, I keep saying size is not an issue, but location is more key. So if you have an exophytic anterior tumor that is up against small bowel, that's something that I would worry about, and something that, there will be increased risk of bowel damage or small bowel damage. So would be the one case where I would worry about.
Got it. Excellent. And Rana, is there any role for systemic therapy for patients with localized small renal masses? We often think about for advanced disease, but what about in this space?
Quite honestly, if we weren't going to do any local treatment, the patient wasn't a candidate for surgery because of comorbidities, also wasn't a candidate for focal therapy, whether that be SBRT or, cryoablation or some other radiofrequency ablation, then I think we really have to think and talk about our goals of care and what do we anticipate is going to be the risk of this renal mass impacting that individual's survival if they're not a candidate for any of the above items. And generally in that situation, I'm watching expectantly as opposed to putting somebody on systemic therapy for a 3-centimeter mass. So I think, it all depends upon the risk of the mass and competing risks in the patient that may impact the patient's life expectancy.
Well said. And I think when we're thinking about any treatment, really weighing the risk and benefits and the competing morbidity and mortality risk we should all be doing that, whether we're treating with surgery, ablative therapies, radiation, or systemic therapy. So excellent points. So for this case, I think we sort of hit these topics. So what we did here is we did surgery. We did a robotic retroperitoneal partial nephrectomy and sort of what we would expect. This was a clear cell RCC. It was low grade. It was ISUP grade 2, pathologic T1A with negative margins. Kidney function didn't change much. So maybe back to Brandon, how do you surveil these patients post-surgery? And is this a patient that you would be calling Rana about to think about adjuvant therapy or no?
Yeah, so for follow-up for these patients, so first of all, this patient has what we sort of expected. So I don't think there was any, curveballs or anything in their post-op path. So hopefully the patient's sort of prepared for this. Again, this is a good prognosis. I would tell the patient based off of this kind of pathology, well over 90% cure rate. So that usually puts them at ease. And because of that, I probably wouldn't pick up the phone and call Dr. McKay for this specific patient. I think we're going to get into a little more of the role of adjuvant, which is obviously a big part of how we manage patients. But in this case, it's still a little classic bread and butter. And so for this one, I would just recommend surveillance. And for me, I pretty much follow the NCCN guidelines, which, I'd usually get a patient imaging about 6 months. If that looks good, go to once a year at this point. And that's how I would follow them. Unless, of course, I had some suspicion about hereditary family genetics, something like that. But that would be the standard.
Excellent. And going back to Rana, when you see a patient post-surgery and just much like the radiation space has changed, really the adjuvant therapy space has changed over the last few years to something that was where we didn't have great options, and with Pembro, with a survival benefit to adjuvant pembrolizumab, we're really talking about adjuvant therapy after surgery more and more. So who are your ideal candidates to consider adjuvant therapy?
I think I revert back to the Keynote 564 eligibility criteria, and that largely included patients who had T2 grade 4 tumors, T3, T4, N1. It also included patients who were M1 resected to NED. And there's some caveats there regarding the sites of resection that were permissible. And that did not include, which we'll get to probably later, people who were deemed NED because of SBRT as opposed to a surgical outcome. So this patient who's got, a T1A grade 2 expectant management, I would not offer any adjuvant treatment.
Excellent. And this patient went on to have NCCN-based surveillance and has done well. So I think we can move on to our next case. This is also a localized case, but this is a 45-year-old man who is found to have bilateral renal masses, no family history of kidney cancer, a few comorbidities that are well managed, and good kidney function. And he comes in with these scans, and I just have one cut of each, but just a single mass in each kidney. In the right kidney, a large, somewhat central mass, and in the left kidney, a completely endophytic mass, also somewhat central, going into the renal sinus. We can start off with Raquib here. You kind of told us before about size doesn't really matter for SBRT, and location, as long as it's not abutting, critical structures, which to me doesn't appear. So would this patient be a candidate, you think, for SBRT based on these imaging?
Yeah, based on this imaging, the left kidney mass is mostly endophytic. Pretty much actually entirely endophytic. A little bit of small bowel is coming about within 1.5 centimeters of it, and that is treatable. The one on the right, I believe the hepatic flexure of the colon is, again, not too close. So yes, both of the lesions are treatable with SBRT.
Hey, Raquib, can I ask a question? Maybe an obvious or silly question. Obviously when it comes to radiation treatment, very familiar with the sensitivity of bowel and stuff. But what about some of the other organs? Do you even worry about liver proximity or spleen? Like in my head, I sort of figure just radiate it. What's the worst that can happen? But that may not be true, I guess.
Yeah, very good question. And I actually hear that often. So liver, as you know, it's what we call a parallel functioning organ. You can cut out half the liver, throw it out, and patient's going to do perfectly okay. There's so much reserve. So liver, we don't worry about at all. Something like that is a serial functioning organ, which is colon or small bowel, we worry about because you damage one part of it, it renders the entire organ non-functional. So that's something we worry about. Spleen, as you also know, splenectomy patients do perfectly okay. So yes, spleen doesn't bother me, liver doesn't bother me, lung doesn't bother me. Large bowel is a lot more radio resistant than small bowel. So large bowel for the most part doesn't bother me too much. Small bowel is the only thing that if it comes to proximity, or if it's up against the tumor, then that bothers me.
Thank you.
Excellent. Going back to Brendan then, this patient comes to you, 45-year-old, multiple renal masses. What are you thinking here, and how do you start to work this patient up?
Yeah, so bilateral renal masses is not an uncommon thing I see in probably you too, Mark. These patients tend to, and I think appropriately so, go to tertiary centers because the level of complexity does jump up once both kidneys are involved. The first thing, that I think any of us do is do a good history and physical. History means a lot. This patient's age is, they have a couple red flags sort of that I would make sure, the trainees that are with me sort of know. One is the age, right? We all know the average age for RCC development still right now is around 64, 65 in the US. So this is considerably younger. So that should be a red flag. In addition, having bilateral renal masses, which radiographically look to be homogeneous, and we know 90% of the time pathology should be congruent. I also tell all the trainees, when you see bilateral renal masses, the diagnosis for clear cell RCC goes down the list, right? Whereas most renal masses we see, that's at the top of our list. When you have bilateral, the development of hereditary syndromes, which can include all varieties of RCC, but more commonly we see the papillaries and the chromophobes and the oncocytomas show up. So that's another sort of red flag. In these cases, I almost always get a biopsy. When both kidneys are at risk, I want to know what I'm dealing with so I can counsel the patient, because sometimes, rarely, you do have to think outside the box. So, and this is the kind of case where if we get some really rare things, we may have to get, Dr. McKay involved. We may need, you can't always just tackle these surgically because sometimes they're hereditary or other medical issues. So history and physical, and then a biopsy, and then I usually try and get them to genetics if I think it's going to affect my management up front. So that's sort of the first couple steps before I come up with a treatment plan.
Fantastic. We thought very similarly to you. So yeah, you mentioned genetics. Just my only question is, I guess you said if it affects the treatment plan. So sometimes before surgery, sometimes after surgery, depending.
Yeah, a lot of times, I'd say about 1 out of 4 cases, I need it before surgery. Because to be honest, most of it comes in handy after you've taken care of the tumors that are there. It's what are you going to do with the next one? How are you going to follow those patients?
In this case, we did germline genetics. Actually, the germline panel was negative. We did a renal biopsy, and it was a papillary type 1 kidney tumor. Dr. McKay, we talked about the use of systemic therapy for a small renal mass in a clear cell tumor. Now we have a papillary tumor, what we used to call pap type 1, now just kind of papillary RCC. Any role for systemic therapy in the localized setting in this disease space?
No, is the simple answer. So there's no level 1 evidence on utilization of perioperative systemic therapy for a localized papillary RCC, whether that be pre or post treatment. Now, I think that this case is complicated, and I think sometimes patients who present with complicated bilateral renal masses, particularly renal masses where they're larger or, T3 or abutting other structures, and they're going to be undergoing a staged approach to target both tumors. Sometimes in that context, you almost treat the individual like a locally advanced unresectable patient and give them, the best upfront systemic therapy for cytoreduction to see if you can potentially convert them to a resectable status. Now, the other thing with this individual is just because one side had a papillary doesn't mean that the other side is also going to be a papillary. When I see bilateral papillary tumors, I think about hereditary screening, germline testing, looking for hereditary syndromes. So that could be considered in this context. But just because one side is a papillary doesn't mean that the other side is too.
Excellent points. Yeah, can't take it for granted. Yeah, concordance rates 75-80%, but you can definitely see mixed histologies. In this case, they were the same though. We ended up doing staged bilateral partial nephrectomies, and they were both papillary type 1 RCC, T1B just based on the size for the right, T1A for the tumor on the left. And then, so going back to Brendan, similar surveillance to the last patient, you think, after surgery?
So, I think all of us know here we have made a lot of strides when it comes to characterizing hereditary syndromes, but I fully don't think we've done all of it. So there's definitely patients that I think many of us who are high volume and see that we're almost sure, like based on looking at their notes, their history, there's something genetic going on, but their panel is negative. And I think that's either because we haven't found the genes or the combination of genes that are doing it. But if a patient has all the other red flags, even if their panel is negative, I will treat them as a hereditary patient in essence, especially these younger patients. And, for the hereditary papillary patients, right, some of these people, have multiple family members, their kidneys look like every other sign is telling you something's going on. They just don't have a gene to tie it to. So in these patients, it sort of depends on what your level of suspicion is for that. And I think inevitably when you start taking care of hereditary patients, you sort of just get a sense of that they're hereditary or something, but not always they are. But for these patients, bilateral, obviously, you're doing 2 surgeries, you're going to probably be following them a little closer for their kidney function the first year or so. So I usually just tie in some imaging at that point. I would probably treat this patient more like a T3 patient for the first at least couple years. And then this is a patient where I'd probably, as long as I can get their insurance to agree, I would follow them longer than 5 years too as well. I try and, do every other year with an MRI or something like that if I can get it for these patients. Because again, part of it is probably just my bias because of the practice I have where I do see patients recur long after our guidelines told them they shouldn't. And that's true for any cancer. But in a younger patient, bilateral kidneys are already exposed. You don't want to catch the next tumor that comes in that kidney when it's any bigger than it has to be, because then you're going to really start losing options for this person.
I agree 100% with your biases here. Who knows what's causing these? This patient could be at risk for developing de novo tumors in the future. I also sort of consider them lifelong risk. We imaged sort of NCCN guidelines for the first 5 years, no evidence of local recurrence, and then started to space out. So went kind of every 2 years after that, just to look for new tumors. Everything looked good at year 7, skipped a year, and then at year 10, returned for follow-up. And boy, did we have a surprise. Nothing in the kidneys, but we saw that along the left renal hilum, along the renal artery, there are these enlarged lymph nodes, a whole chain of lymph nodes. And so I guess going back to Rana, can you kind of walk us through if you have a patient that you suspect may have either locally advanced or possibly metastatic disease, what is your sort of go-to staging scans? What do you recommend? What do you not recommend?
Oh, very good question. So I generally like to get imaging of the chest, abdomen, and pelvis. Depending on what is going on in the abdomen, sometimes MRI may be preferred over CT. If patients had a nephrectomy and there's something in the nephrectomy bed and you're not really quite sure if it could be post-op changes, sometimes an MRI may be better suited. In patients who have overt metastases, sometimes brain imaging is indicated. It's not necessarily indicated for every single patient, certainly anybody who has any neurologic symptoms, of course. But in my practice, if somebody is stage 4 metastatic, I do tend to get MRI brain imaging, even in asymptomatic folks, just more so as a baseline. Now, there's a lot of interest in PET imaging in these patients. FDG PET is really not indicated. There are some tumors that are FDG avid, some that are not, and it's not necessarily used in the diagnosis, though there are other PET modalities that are being developed in RCC, PSMA PET imaging, because these tumors tend to have a lot of vascularization, which can be detected on a PSMA PET scan. And there's also CA9 PET imaging. We saw some really nice work presented at ASCO by Michael Hoffman and the Australian group on the advent of CA9 imaging for diagnostics. So right now, my tools are CT of the chest, CT or MRI of the abdomen. If I'm suspecting a recurrence, I do generally like to biopsy. Not every, enlarged node or lung nodule is a recurrent disease. So I do like to do those diagnostics.
We did obtain PET here to assess for a clinical trial eligibility, in addition to all of the other sort of head-to-toe staging imaging, negative brain imaging. We had a bone scan that was negative, and we just had disease that was confined to the retroperitoneum. I'm just going to go back to the CT imaging here. Back to Raquib. If we're thinking about options for this patient that has locally recurrent kind of nodal disease, we'll talk about what all is on the table. Could SBRT be on the table for this, or are we proximity to the adrenal a concern? I don't see any bowel loops. There are some bowel loops close to. What do you think?
So adrenal, if the patient has the contralateral intact adrenal, then it is not an issue, because that will compensate for it. Yes, I agree with you, not too much bowel. So radiating and getting local control on these nodes is feasible with SBRT. The questions to answer there would be, oftentimes with other tumors, whenever there's node involved, we cover elective nodes. So we think, maybe a little bit superior, inferior, or on the pathway, there could be micrometastasis. Whether elective nodes should be covered or not, that's something we don't know or we don't have the data for. But yes, local control with SBRT for these would be feasible. And there is the oligometastatic paradigm, which is another perhaps separate topic. This perhaps would fit into oligometastasis if no other sites of metastasis is present.
Excellent. Biopsy was obtained here too. It demonstrated what we thought it was, metastatic papillary type 1 RCC to the nodes. So Brandon, you see this patient now 10 years out, locally recurrent nodal disease. Is this a surgical candidate in your mind? And what operation would you do if he is?
Yeah, so papillary is still one of the few tumors in RCC that we can cure patients even after it leaves the kidney. And this is a case that, many of us, again, who do this this happens with the papillaries. More common in the papillary type 2 historically than the type 1. It's a little surprising to see that those typically are not as aggressive. But given that they tend to go to the lymph nodes much more than the other RCCs we're used to seeing, it does offer a therapeutic window if you can catch the patients, and it looks like you may have, to offer them potentially a curative option with surgery. So this patient I would counsel and probably recommend, because this patient's still only, 54 or something, pretty young and hopefully still healthy, a full retroperitoneal lymph node dissection. I think you could make a decent argument they probably don't need a full one, maybe just a templated one over on the left side. But my preference is this patient's already got a surgery on one side, a surgery on the other side of their kidney. Now you're putting a big surgery on them. I don't want to go back. Nobody wants to go back after this one. So I would clean them out just to make sure I offered them everything I could.
Fantastic. And Rana, if the surgeon doesn't feel confident that they can clean out, or there's some contraindication, what can you offer from a systemic therapy perspective for someone with type 1 PAP? Or are you going to a clinical trial, or kind of what are your thoughts there?
I mean, I think for all of our variant histologies, we are absolutely targeting a clinical trial. I mean, it is critically important right now. There's PAPMET2 that's enrolling throughout the cooperative groups. This is a critically important trial that's testing the role of TKI-IO in patients with advanced papillary RCC. And I think we as a community need to get behind these studies. Also for the papillary tumors, there's another study being conducted through the ETCTN looking at beverlotinib plus atezolizumab. It's for both sporadic and germline HLRCC. So I think we need to get behind these trials. In the absence of a trial, or one may not be eligible for a trial, my go-to is an IO-TKI combination for these patients. I don't necessarily think it's wrong to consider nivo-ipi or single-agent TKI, but I think the best responses are going to likely be observed with that strategy. I think when we think of IO for these patients, i.e. nivo-ipi, the primary PD rate is even higher for papillary RCC, closer to 30%, 40%, and then the objective response rate lower than what's classically seen with clear cells. So I think we need to think about that. In this context where you have somebody who's got not a large volume of disease, has retroperitoneal nodes without other sites of metastases, where there could be a possibility to kind of significantly cytoreduce them or get them into a CR or near CR, leaning towards an IO-TKI combination that has a pretty high response rate and low primary PD rate, where then you can potentially think about a surgical strategy could be a possibility.
I have a question for Brandon on this case. Given that this patient had previous surgery, would you worry about adhesions or other difficulties in your surgery?
Yeah, you always worry about that, but the first two, it looks like were done robotically, so I wouldn't expect it to be horrible. But saying that, that's why I mentioned I would go into it, and I always tell the patients that, I want this to be your last surgery, right? That means I've done everything I can do. So I would do this open, which is how I do most of my RPL&Ds anyway, just to ensure it's the safest, most therapeutic, and hopefully the last operation. But the adhesions I wouldn't think would be terrible in this patient.
Excellent. In this case, we ended up doing a robotic RPL&D, and we did a left-sided template. Patient had 5 out of 20 lymph nodes positive for papillary type 1 RCC. I agree with Brandon. I do almost all my RPL&Ds open, particularly if there's disease behind the vessels. Here, there was kind of good space between the aorta and the nodes, and we were thankfully able to get in and with few adhesions. And afterwards, the patient is on surveillance every 3 months, and we want to get them to many more years, hopefully. So with that, I think let's get on to case number 3, and this is actually one of Brandon's cases. It's a 51-year-old man with new onset right testicular swelling with concern for a right-sided varicocele, I believe. And so I was getting worked up for that with an ultrasound and a CT. Actually, we just want to pause right there, Brandon. Maybe, we think about this as surgeons, but kind of tell us, is that odd to have a right-sided varicocele? Is that something that we see commonly or what?
Yeah, so this is I just remember when I found this out, and I don't know if it happened to you, Mark, when we go through training, it's like when your first year anatomy class comes back and you're like, oh my gosh, I remember. So it is not uncommon. You actually see it. I think it's on our boards. You see it in question sets from time to time. But because of the gonadal vein for most guys usually comes off the IVC, if there's an occlusion or blockage of that IVC, those patients tend to develop varicoceles on that testicle, which most guys usually complain of the varicoceles as a dull ache, pain kind of stuff. So while it's rare, I think any person who does this long enough gets these cases where they come in with no other complaint than my my testicle hurts. And it's the right one as opposed to the left one, which can happen too, but you just see it less often. Because of the anatomy that's usually coming off the left renal vein versus the IVC itself. So it has more collateralization to work with. So it's always an interesting thing when this happens.
Excellent. So this patient comes in, get this workup, gets a CT, and kind of walk us through this. This looks like a nasty process going on in the right kidney. What do we have here?
Yeah, so he was a incidental finding, sort of surprisingly, other than the testicular pain, I guess. But it's hard to capture, I think, on a still image, but you can see pretty clearly that it's really difficult, if not impossible, to make out his IVC. And this sort of continues if you scroll up and down for a good 6 centimeters along the IVC. So I realized that whatever disease process going on, sometimes it could be hard, although this patient didn't have a history that fitted, but sometimes patients will have some spontaneous bleeds or a trauma event, and that blood, that capsule, which you can sort of make out a little bit on this patient too, can sort of fool you as, is this tumor, is this blood? If I wait it out, will it go away? It's hard because if you wait it out and it's not blood, guess what? Now it's grown bigger and you sort of missed your window. But if it's blood, you can sort of maybe get a little pullback. But I was concerned in this patient because he didn't have that history. I had to assume this was all tumor that was basically encasing his IVC. So in addition, as you can see, he's not terribly old. He wasn't the healthiest patient. So this is sort of one of those cases where I knew we had to think a little more outside the box. And so I knew surgical resection, if I got in there, was going to be a major thing. I don't think I'd probably have to either graft his IVC or leave it in discontinuity, which, if you have to do, you have to do. But this patient, and I don't think we've said it yet, if he had other options to try and shrink this tumor or facilitate the surgery so I don't have to do as much. In addition, we sort of use it as a time for him to get himself healthier, stop smoking, stop drinking, lose some weight. And so there was an opportunity to not only maybe shrink the tumor, but optimize him as a surgical candidate as well.
Excellent. And just some more images here, and you can really see the extent of this process involving the IVC. And like you said, you kind of really lose the IVC sort of just below the renal hilum up to the edge of the liver, hard to make out. So you talked about taking some time to try to shrink the tumor and get him optimized for surgery. So I'm assuming that you are going to ask for a lifeline from your medical oncology colleagues here. Is that correct?
Correct.
So Rana, the urologist has this patient with a IVC tumor thrombus and a large tumor and has the intent of hoping to downstage for surgery. I'm sure this is a type of patient you see in your practice. How do you manage these patients?
So I would basically put this individual in the category of locally advanced unresectable. These patients were actually included in all of the phase 3 trials that tested various IO combination strategies. I think in the context of potential resectability down the road, where you're really looking at a regimen that's going to be associated with the highest response rate, the lowest primary PD rate, the fastest time to response, so you could potentially get them to a potentially curative surgery, I generally go with an IO-TKI combination and generally lenvatinib, pembrolizumab in this context.
Excellent. So it looks like in this case, the patient had a biopsy, of course, confirmed that this is clear cell RCC, and then started on Axi-Pembro. Rana, can you just go back a little bit and tell us a little bit about sort of the kind of anticipated speed of response with TKI IO versus IO and how you think about if you want to get quick shrinkage? It sounds like you're going TKI IO. Is that correct?
Yeah, I mean, I think if we think about Nivo-Ipi, for example, like the primary PD rate's about 20%, which is a high primary PD rate for somebody you're trying to get to resectability. I mean, the caveat that I would use there is unless the patient had sarcomatoid differentiation of some kind. And also the response rate's around 40%. Now that response rate means 30% shrinkage or more. When we look at the data for example, lenvatinib pembrolizumab, the primary PD rate is less than 10%. The response rate is actually close to 70%. I could see the rationale for using axitinib. Axitinib has a short half-life and, is a favorable TKI when we think about stopping the agent for planned surgical resection. But those are kind of the considerations to be had. I think you would expect timing-wise to see best response within a couple of months with an IO-TKI combination.
Hey, can I ask a question real quick for Rana too? So, traditionally, and I don't know if you're still in this game because you mentioned it, if say the biopsy showed sarcomatoid elements, and we always think ipi-nivo when we see sarcomatoid, but do we really have data that shows that it's better than any other IO-containing regimen when it comes to sarcomatoid response?
We do. I mean, it's never been compared head to head, but I think if you're actually looking at the response data, the response rate is doubled in that population. And actually what's really striking is the durability of response is much more pronounced in those individuals. So when I think of IO, we have 1 in 5 patients that have really no response, have primary resistant disease. We have 1 in 5 patients that can have a durable response. That's just your kind of all-comer population. I think if we were to apply this to sarcomatoid, we really are bumping up the tail on the curve. And we see that when we look at the PFS curves, actually in the subset analyses, though they're post hoc, demonstrating, sustained durable response or durable benefit in that group of patients.
Thank you.
And Raqib, is there any role for radiotherapy to treat disease that's in the IVC? Is there any data for efficacy? And on the other side, is there any concern for treating disease with major vascular invasion?
Yeah, not too much data that has matured yet. And we have, started gaining some experience with this, mainly started with treating a few cases of refractory and patients that are not eligible for surgery. And we started seeing actually very good 70 to 80% radiographic measurable response with radiation. So we went around, because these cases are so rare, combining a case report from multiple institutions that we published a case series of 15 patients, and now we're updating that. And we also have completed now enrolling on a small phase 2 feasibility trial of neoadjuvant radiation followed by surgery and nephrectomy. That trial we hope to publish in the next couple of months, and it is feasible and safe. Now I'll go over a few indications that we explored. One of them is the neoadjuvant, one of them is adjuvant, and another would be palliative. In a neoadjuvant case that I can remember, a patient similar to this, but a little bit more, a larger level 4 thrombus with Budd-Chiari syndrome, so venous congestion. So that patient was not a candidate for surgery up front, but after SBRT of full dose, within 3 months, the patient's ascites resolved, LFTs normalized, and then we had MRI showing that the venous congestion also relieved, and then patient was a surgical candidate and underwent surgery. So that was one case. Another case was an adjuvant case. So that is something that could apply to this patient, where the patient wasn't really in good shape, like this patient, for an extensive surgery, but the patient was a candidate for a nephrectomy, a robotic nephrectomy, which is a much less complicated surgery, as you know. So in a planned way, the patient underwent robotic surgery, and the thrombus we gave local control with stereotactic radiation. So both together combined, the patient overall had local control. So this is something that I would like to eventually explore on prospective trials, because in many tertiary care centers, community setting, patients don't have access to surgeons that can do extensive surgery, but they will have surgeons who are able to do nephrectomy, and combined with radiation, you could probably give local control to these patients. So an area that we are exploring, and the data is maturing, but we don't have long-term data yet.
Very cool to hear, and look forward to seeing that for sure, to have more options for these complicated patients. So it looks like this patient went on to receive oxypimpro, had a decrease in the size of this mass, and sort of stable lymphadenopathy over the next 6 months, developed, had some complications, DKA, ICU admission, and then 6 months later sort of was reevaluated for surgery. So Dr. Manley, now we're a few months down the road. What do you see now compared to when you started?
you can start to make out the kidney, actually, which is something you couldn't do before. You can actually see part of the IVC, which you couldn't see before. So those are all good signs. So, this was early in the experience for me of giving, this wasn't standard of care. It's still not, but this is a case I think definitely deserving of neoadjuvant treatment, although some people could argue you could have resected him up front, but I think that would have been a tall task. So I think we had a really great response. The sad thing was he did develop lifelong diabetes, so it's not without cause, but I still think and know the patient would do it all again if they needed to. So they had a really good response, and this sort of is an emerging problem, I would say, or situation. I'd be interested to see what your take is, Mark. After these patients have a good response, right? However you want to characterize that, decrease in size, change in enhancement, whatever. When do you offer these patients surgery and when do you not? Because, now that we're seeing more of these patients come through and they still have their kidney intact and it's the only area that has any disease, do we really always go in, and take these out? I sort of, a little bit, right? Some of these patients will start getting hits to their kidney too with treatment too. So now they're not the same kidney function when you first met them too. So I'm interested, I've sort of adapted, but I'm interested how you sort of triage these patients, Mark.
Yeah, it's a great question, and there's not an easy answer to it. The PT0 rate, in my experience, is on the lower side, but it's definitely not zero. There are some patients that can have a complete response in the kidney, and then others who their disease is now somewhat more quiescent. Most of these patients, I would say, probably do end up having a resection if they are otherwise, if we deem it resectable, we can do it safely, and that we think the competing risks are favorable. And we do find viable disease more often than not, but are happily surprised when we get a YPT0, right? Sometimes these surgeries can be very challenging, especially after IO therapy and when there are big lymph nodes around the vasculature. Sometimes you get a desmoplastic reaction, and then sometimes you don't really have any desmoplastic reaction at all. It's not like post-chemo testis cancer, right? So it's definitely a little bit of a box of chocolates.
And Rana, I'm sort of interested in, do you just send them to surgery? But the surgeon will tell you if you need surgery or not, or because you probably see these more and maybe they don't always come to us. And when do you decide, hey, I think that kidney needs to go or not, I guess?
Yeah, it's a very interesting conversation. I think we have a multidisciplinary tumor board actually that meets every Friday afternoon where we actually bring these cases, and there's a assessment by a radiation oncologist, medical oncologist, and surgeon, and have a weekly tumor board as well. So I think that these are dynamic discussions. It's I can't emphasize enough the importance of just continued communication and collaboration, because there's things that I may see or have sort of insight into that maybe one of the other multidisciplines may not, and vice versa. There may be aspects from a surgical standpoint that I'm just not aware of that I will be enlightened by sort of reaching out to colleagues. But I think in general, my rule of thumb is, if they've had 2 serial scans where they've maintained a sustained response with no other evidence of disease progression and they're clinically doing well, that's generally when I'm pulling the trigger to say, okay, let's have you go back and see the surgeon. I don't generally jump on the first scan because I want to ensure that response is maintained. There's been so many times where you kind of jump the gun too early and then you stop their systemic therapy and you're getting them teed up for surgery and they met out in the middle of that process. And that's the worst thing you could do for somebody. So I like to ensure that there's sustainability in the response before we pull the trigger on actually taking somebody to the OR.
Excellent. So Brandon, what did you end up doing here?
Did surgery. So it was stuck. It was which again, sorry, I feel like it's just me and Mark complaining about being surgeons, but it was so stuck. And when you looked at that scan, it looked so much better that I think I got tricked a little bit, but it was really, really stuck. But we did discuss some of these other options. And again, we'll talk about it probably in a little bit, but we got him through surgery and he's doing fine. And I don't know if I do anything different in his specific case again, but it has made me question other patients I saw subsequent to this about, how to handle them. And every situation is different, but we ended up doing surgery, just an open radical nephrectomy, because I knew it would probably be stuck and wanted to make sure the vessel, we had good control. But it was definitely more plastered than I thought it was going to be. Because like you had mentioned, I've done several cases of patient systemic treatment before, and you always hear these horror stories about don't do it if it's cabo, or no, IPI's the worst, or, this one's the worst. But in my experience, I really haven't found one that's worse than the other. It's just that sometimes some patients, it's like horrible, and other patients, it's like they never had anything.
Interesting. And did you have to do anything to the cava?
Yeah. So basically, I sort of took a side swipe of it. So oddly enough, this is, and again, there was no way to know. He never had a thrombus, and that's what I was worried about. The thrombus was never in there. What had happened is basically the tumor just closed off. It just, and you see this sometimes in testes too. It just basically, compressed the IVC, and it had probably been there so long it just, wasn't functional. But so, when we didn't have to do a whole graft because it was slightly less than 50% of his circumferential IVC width. And considering that he had practically had no IVC before we started systemics, it was new blood flow. And so we didn't have to do, luckily, as much vascular work as I was fearing.
Fantastic. All right, then. Let's move on to our last case then. Another case of Brandon's, actually. 62-year-old man, this time presents with gross hematuria. Looks like has some diabetes, some fatigue, some weight loss over several months, and an unremarkable physical exam. And to work up for all this, get some scans. So, Brendan, if you wouldn't mind again, tell us what you saw in these scans. And
yeah, so I think these highlight pretty much, but his primary tumor is on the left side. I think it's something around 10 centimeters was the total tumor diameter, and very central, looks malignant. He also had a contralateral right-sided adrenal lesion that also looked highly suspicious, along with a lung nodule, and then in the left side, I think actually he had bilateral adrenal nodules, with the right side being the bigger. So those were the sites of disease that we identified. Everything else was negative.
So large renal mass and suspicious areas look like metastases, bilateral adrenals, and in the lungs. You've got no brain is normal, no bone mets. So it looks like we've characterized the sites of disease. So, this seems like the type of patient that would be presented at a multidisciplinary discussion. So, Rana, the role of surgery versus upfront systemic therapy has really kind of maybe shifted over the past few years with Carmina and Surtime and other trials. For this type of patient, every patient's a little different, but for this patient, what do you think the best next step would be?
Generally, for patients who present like this, I am leaning towards systemic therapy first. And then it's not to say everybody's going to get resected. That's not the case, but a consideration down the road. I think it's really important to guard against patient expectations around surgery. I think a lot of times, depending on how the patients are kind of, being seen or being evaluated, or who sees the patient at any given time, I think that, you could really do somebody a disservice if they have it in their mind that they're going to, at some point in time, get resected, and that's just going to be an expectation. So I think I level set and say, this is a systemic disease. You have a system problem. You need a system treatment, which is immunotherapy based. And then depending on what happens, we can always reassess surgical options, though that is not the primary goal here. So I try to level set that discussion up front.
Yeah, I think that level setting, the importance cannot be overstated. I would definitely agree. And I think in my center, this patient would likely get systemic therapy first. Before we delve into the details here, though, are there any types of patients who present with metastatic disease that you do consider maybe surgery first, and that could be because of histology, or maybe because of the location or amount of metastatic disease? Do any of those things factor into your calculus?
Yeah, no, very good question. I think that, yes, it does. I think there are some individuals who are young, healthy, maybe have very low volume, minimal lung metastases, and that's really the only thing that's designating them metastatic. They've got the bulk of their disease is in their kidney as opposed to outside their kidney. They don't have poor risk features. They don't have this inflammatory phenotype of anemia, thrombocytosis. Their calcium's not dysregulated. So I think they have their only IMDC risk factor is that they basically presented with metastatic disease at their initial diagnosis, but they're otherwise well. So I think in that context, it makes sense. I have had patients who have had very symptomatic hematuria at the time of their presentation, and otherwise had low burden disease, where it made sense to treat the renal primary with a surgical resection. I think sometimes in that context, we're actually embolizing to deal with the hematuria and then get them on their systemic therapy.
Excellent. So for palliative purposes, and I think it was maybe one of the European guidelines, at least a couple of years ago, that was if the amount of metastatic disease wouldn't warrant immediate systemic therapy, so maybe that low volume lung only disease, and I've carried that as a helpful heuristic for me. Okay, great. So so it looks like this patient did go on to receive systemic therapy, Lenva and Pembro. Back to Rana for a second, is we talked in the last scenario about sort of your preferred regimens for unresectable local. Would you agree with the treatment here, or what are your thoughts for a patient who presents like this?
So I think actually in this scenario, I'm a little bit shifted. In the other scenario where you had somebody who had localized disease, who maybe was borderline resectable, and you're really trying to get them to a point where they could undergo a curative intent therapy, I think the goals of care are a little bit different there, where I do want to get them maximally cytoreduced with a regimen that's associated with the highest response rate and lowest primary PD rate, which is the IO VEGF TKIs. But in the context of somebody who's overtly metastatic, like in this scenario, even though they're intermediate risk, we've demonstrated long-term disease durability with IO that we just have not seen with the other regimens. And so while 1 in 5 progress and the response rate is numerically lower compared to the IO VEGF regimens, 1 in 5 are going to have a long durable response and potentially even cure. So I think that is an important thing to consider when you're treating somebody with metastatic disease. And also the other piece to it, from a quality of life standpoint, though there are immune-related AEs that are associated with the chronicity of long-term TKI treatment, can have a negative impact on quality of life as well. So I generally favor nivo-ipi to give that individual the greatest chance of a long, durable remission. And then if they do progress, favor VEGF TKI monotherapy strategy.
I do have a comment here.
Please.
I think Rana may be too shy to mention that she is leading a trial that this patient may be eligible for, the Samurai trial, which is exploring the application of debulking with stereotactic radiation in the setting of metastatic disease where primary is intact and the patient is starting an IO-based regimen. And we are trying to take advantage of both the immunogenic properties of stereotactic radiation, which is not clinically established yet, but has a lot of preclinical data, but at the same time debulking with the radiation. So again, we will not know until the trial matures. Cytoshrink, a similar trial, actually completed enrollment, but I have not seen the data for that yet either.
So that's fascinating. So I'll ask you both. So is the intent here to treat both the primary and the metastatic sites with radiation, or just the primary?
Just the primary. Yep. It's a trial of combination IO therapy, any standard of care combination regimen for patients presenting with de novo metastatic disease with an intact primary, and they're randomized between radiation to the renal primary versus observation with their systemic therapy of choice as selected by their investigator.
And the thought is that the radiation, there might be some immunogenic releasing antigens, and maybe the abscopal effect. Is that, am I reading too much into that, or is that one of the thoughts?
Well, I think it's actually multifactorial. I think it's one, cytoreduction with SBRT actually, as opposed to cytoreduction with surgery. And 2, could there actually be a synergistic effect with the IO therapy? So I do think it's the combination of the two.
Fantastic. So in this case, the patient went into systemic therapy, and it looks like, Brandon, like things were fairly stable over the next little while, really over the next couple of years, other than the patient developed some CKD. And then I guess a little while later, a couple of years later, we have this. So walk us through what we have now.
So in essence, the patient was on treatment. I hadn't seen him for a couple of years, seen one of my colleagues, but came back to me. I don't know if they met the qualifications that Dr. McKay said. They've had more than a couple of scans. Nothing else has shown up. The lung stuff went away. And it's left with basically 2 tumors. So the left adrenal one is gone, but the right one is still there, and the left renal mass is still there. And so I think this sort of probably borrows a little bit from our past conversation, what do you do with these patients now? And I think one thing maybe Dr. McKay can speak on, because I think this is also new, is historically a lot of our kidney cancer trials really were cognizant that many patients were coming into the trial probably with poor renal function, right? They already had their kidney removed, because that's used to be, I think, the early trials, the Mozart trials, 90% of patients had one kidney, right? So everything was sort of designed. But I've noticed some of the newer trials are starting to have, renal function qualifications for getting on trials. And in fact, this patient, because their kidney function took a pretty big hit with just the systemic therapy, this is a patient where I would feel really bad if I went and took out that left kidney and it was all dead tumor, and now he's not eligible for some trials. So I don't know if you can comment, Rana, about how the field sort of changed a little bit in having some of the inclusion-exclusion criteria around the renal function of patients, because that seems sort of new to me. I don't know. Maybe it's not.
I mean, I think in the metastatic setting, I think we are a little bit more generous with our inclusion-exclusion criteria, but I think that especially around renal function, and that varies. If it's a phase 1 study, it's obviously more restricted. If it's phase 3 study, it's broader. I would pause and ask, why did this patient have renal dysfunction while on treatment? And what is the cause of this person's renal dysfunction? Did they have ridiculous sarcopenia at baseline from the disease, and they've actually been able to stabilize and gain some weight and gain some muscle, and this renal function is more reflection of their normal state? Or did this patient develop a nephritis? Like, what's going on?
There's no smoking gun, I can tell you that. Everyone sort of chalked it up to just cumulative IO. It sort of happened slow enough that nobody really sounded it's not like it came in for one lab meeting. It was like, oh my God. But when I looked back, I was like, nobody really even noticed it. And I don't know. Yeah. That's just because it happens a little tick here, a little tick there, and you just look. So I don't know.
Right. Like, so it's just kind of one of these things. Like I think these things can happen. And does it correspond with like a parallel increase in weight? I see that all the time. Patients they do better, they gain weight because they've lost weight, and then their creatinine goes up, and it's because they've actually gained a ton of weight. But sometimes these patients need to get in, see a nephrologist, and actually get a biopsy and make sure they don't have nephritis, which can be reversed with steroids, actually, if that's what's going on. So that's where I was getting at.
At this point, he was already off treatment too. There was nothing more, and he wasn't having any other symptoms. So that was sort of the rationale, I guess.
Yeah. I mean, I think we have to think about, like, what's the ultimate goal, right? Like, what is the goal? Do we think that this person is going to have, like, is the goal of therapy cure? Is it, like, what is actually our goal? So in the context of somebody kind of having been cytoreduced to this point, and you're really running up against it from a GFR standpoint, I don't know that I would subject an individual like this to resection. I mean, also looking at the location of that tumor, I'm not a surgeon, but that central location makes me a little nervous about how much, even though the rest of the renal parenchyma actually looks pretty good, but it's just location looks concerning, so, but I tend to have a more conservative strategy, I guess is what I'm saying.
Systemic therapy stopped at this point, stable disease, and 2 locations, this mass in the left kidney and this right adrenal. So multiple options on the table here: surgery to remove everything, more systemic treatment, monitor, radiation. Let's just go back to Raquibul for a second. Based on what you've taught us, these look like decent locations to consider SBRT. Would you say?
Yeah, I agree. They are feasible and treatable safely and effectively. Again, if there's no viable disease, then perhaps I would wonder why. Maybe we watch and see whether there is any activity or growth. And if there is, then we take them out with radiation. But yes, radiation is an option.
Now, do you typically require, or at least want, a biopsy before treatment? Or I guess it depends.
Yeah, that depends. I mean, goes back to the earlier discussion we had. I mean, nowadays with MRIs, you're getting so much information, and you're almost, confirming the diagnosis. For this patient, of course, before IOTK, I perhaps had a biopsy to confirm the histology. So we would not need another biopsy.
Okay, so Brandon, what did you end up doing here?
So this patient I watched, and he's a year out, and I think this is an area that both for the surgeons, do you operate or not? But to Raquib's point too, do you radiate or not in these scenarios? It's equally same problem. I think One is we probably need a little more data on the radiological side. Some groups are looking at this. How can you tell if there's viable tumor there or not? And I also think it's probably going to be a space where we start biopsying more of these lesions, just to try and prove it. For this one, radiographically, you can sort of tell like it looks like a dead tumor, right? There wasn't really enhancement. It's sort of rim, looks necrotic. And so I sort of learned the problem with this guy is he had both adrenals involved at the beginning, and I didn't want to take both his adrenal, right? If you're going to go, that means both his adrenal goes, kidney goes, creatinine goes over too, which I talked with the patient. And this is again where I'm having to get more, historically I never had to do this, but I sort of talked with his medical oncologist, said, hey, if he progresses, what trials are you looking at? And then we looked at the inclusion, exclusion of those trials. And one of them was specifically, it was to his GFR. And so when I told him that, he was like, no, that trial was his baby. It's like, I don't want to lose that trial. He really loves that trial. And so, we agreed there's risks and benefits. But, I think, again, how to select which ones you watch, which ones you don't, I think is still a moving target.
Well, I think that's certainly a thoughtful way to proceed. So that's great. I think we're at the end of our case discussion, and I think we're almost at the end of our time together here. I guess I would just ask the group if there are any words of parting wisdom, that things that we haven't covered that you think our listeners should know about how we treat kidney cancer in 2025. Rana, any other things from your perspective?
I think hopefully from this discussion, you've all gathered that this is becoming an increasingly more complex disease to treat that is truly multidisciplinary. There's so many intersection points where the three disciplines, medical oncology, urology, radiation oncology, coming together, and even with pathology and radiology as well. So I think it's becoming increasingly multidisciplinary. So it's been a great discussion.
Excellent. Raqib?
Yeah, no, completely second that. Raina sums it up very well. I think I'm really excited that we now have the technology that we can bring radiation as an option to patients and in many stages. And it really is a very intricate multidisciplinary management, and onus is on us to try to find where we can fit radiation for the patients.
Brendan?
Yeah, I just want to, thanks for inviting me, Mark. This is awesome. Rana, Raqib too. I think it'd be exciting. Maybe we do this again in 5 years from now and see how much has changed, because I'm imagining if we did this 5 years earlier, it's really great for patients to see all these amazing options, things that, I remember in my training, there was one size fits all kind of stuff, and that's definitely not the case now. And that's really great for patients.
Kidney cancer is certainly a fascinating and humbling disease, and we learn a lot from each other. We learn a lot from the patient in front of us, and I've learned a lot from the three of you. So thank you for joining us. And again, on behalf of the SUO and on behalf of BackTable Urology, we thank all the listeners for tuning in, and we'll see you next time.
Thank you.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.